Good evening, my name is Pablo Ramirez, and the claim I will be refuting today is that doctors are prescribing pharmaceuticals in the United States as a quick yet dangerous solution to patient problems. So my opponent's secondary claims, the first one being doctors in the U.S. overprescribe antibiotics with dangerous consequences. His second claim was that patient demands for painkillers from doctors in the U.S. have led to the opioid crisis. And the third being that doctors in the U.S. overprescribe psychiatric medications as a replacement for therapy. So in response to his first secondary claim, Davis claimed that 1 in 3 antibiotics for viral infections is actually false. So actually, after going through his cited material, I looked at one of his sources, and the closest statistic that there was is that 1 in 3 antibiotics is listed as unnecessary. They're listed as unnecessary. So the difference in this is that he's actually misrepresenting the data by saying that 1 in 3 antibiotics is used for viral infections, which would mean 33% of all antibiotics that are dispersed, or they're pretty much of no use. But going through the CDC website, it reads that that they're unnecessary, with only a percentage of those that are considered unnecessary being actually used for viral infections. And another claim that he had made is that, so the way that he phrased it is saying that that it's being done on purpose, that antibiotics are being purposefully given knowing that they have no useful effect. And there are according to the American Academy of Pediatrics, there are currently no practical tools for clinicians to use to distinguish from viral infections as compared to bacterial diseases. So in that case, doctors actually have to make their best judgment when it comes to what a patient what they have to be administered. And then also according to the American Academy of Family Physicians, it's the responsibility of the patient for their overall well-being. So even though there might be things that cause ferment later, even though the doctors prescribe antibiotics, it's not necessarily their it's more on the patient to take care of themselves than anything. Then Davis's last point actually has he actually stated that the frivolous use of antibiotics allows for extremely dangerous antibiotic-resistant bacteria to develop. There was actually no citation for that last one, and there's really no statistics to give that antibiotic-resistant bacteria has increased as a result of it. So in response to the second claim, patient demands for painkillers from the doctors have led to the opioid crisis. According to the CDC, there is actually many listed attributing causes to the opioid epidemic. Most of them have to do with drug abuse and overdose, which isn't doctor caused, it's more patient caused. So that's nothing that the doctors can control. So even though they prescribe antibiotics or anything like that, it's really not up to the doctors, it's up to the patients whether to use them responsibly or not. I had read an infographic according to the U.S. Department of Health and Human Services, and it was actually blaming on the infographic, it was saying that illicitly manufactured fentanyl, a synthetic opioid 50 to 100 times more potent than morphine, is primarily responsible for the rapid increase. So in response to the opioid epidemic, once again, the key word here is illicitly, so it's not given by the doctors, it's not administered by the doctors, it's what's found on the streets, what patients could get a hold on their own. So that's really not up to the doctors. In response to his third claim, that doctors in the U.S. overprescribe psychiatric medications as a replacement for therapy, Davis really failed to give any details about what sort of qualifications doctors need to have in order to properly prescribe or properly address those situations. And based on the statements alone, it would appear that doctors are taking a shortcut by not taking psychiatric training and things needed to address those patients' needs. And he failed to point as to why exactly that training is not being forced upon doctors if it's really such a big issue. And all this being said, this is why the overprescription of pharmaceuticals given by Davis isn't really the best. Thank you.
All right, Pablo, the organizational stuff is fine. You label the main proposition and the secondary claims. That's good. You do signposting on the individual points as you get to each one. That makes it easy to follow the argument. On the first point, I think that you are picking at straws here. You know, it's a very thin kind of thing. You're making this argument about the 1 in 3 at 33%. And you know, the question is, what percentage of the 33% is really not viral or are viral infections that can't be treated with it, and what percentage is something else? I'm not exactly sure that it matters that much one way or the other. The argument that the advocate is presenting is that the material is not useful for whatever the illness happens to be. I think you've got a much better argument in the second part, which is that doctors can't tell necessarily whether it's going to be useful, and so they have to use their best judgment. They have to make an inference, and they worry most about the benefit to their patient, and so that's why they sometimes prescribe an antibiotic even if they're not sure a person has an infection as opposed to a virus, that kind of thing. And I think that's a good argument on that. It's inelegantly explained when you present it, but that's really the position that you want to be taking here. Is it's not that doctors just give people antibiotics to shut them up and get them out the door. Doctors give them antibiotics because they think there's a possibility that the antibiotic is going to help either with the primary source of their problem or secondary issues that would come up because of the problem. And that seems like a legitimate reason for prescribing those sorts of things. Then you kind of challenge the issue about resistance, and I don't remember how much information the advocate provided on those points. You basically say there's no information on that, and if there isn't any information, then we probably shouldn't be listening to that argument at this point. On the opioid addiction issue, I thought that you had a good piece of information, that you mentioned it yourself, you highlighted it, that this is a result of illicitly manufactured opium or opioids, synthetically produced, which suggests that this is outside of the purview of doctors. Now, do people get connected to opioids originally through their doctors? That might be the case because they had pain issues or something that had to, that they needed assistance with. But the abuse part, I think you are drawing a good line here. It says that's not the responsibility of the doctor. The patients are the ones who become abusive in this, and then they seek these materials outside of the healthcare field, and that's not the responsibility of the healthcare field, and that's a good cause-effect claim there. You're arguing an alternate causality on that particular point. I didn't really get what your point was on the psychiatric treatment issue. It was a little bit vague and unclear, so you need to be a little bit sharper on those points. All right, thank you. Janelle.